Welcome, everyone. We continue with the program of the second day of the Digital Health Society Summit. The topic of the day is connecting the dots between innovation and knowledge in our communities. And this is here in this panel discussion, we take directly where we finished the fireside chat with Angela Brandt on the cultural and regional aspects influencing digital health adoption and upscale. I'm pleased to introduce your moderator, Carina Dantas, who is the Senior International Projects Manager at the ECHAlliance. And we have with us 4 distinguished speakers, digital health professionals, public health professionals, 4 fantastic ladies representing the international innovations, international projects that develop digital health solutions and innovations. So with this, I would like to hand this virtual microphone to Carina. And yeah, the floor is yours.
Thank you so much, Carolina. And first, thanks to the 4 speakers that were so kind to be here with us today. As Carolina said, well, we have a women's panel, so I do hope it will be challenging and that we will keep the pace and have a lot of interaction also with our participants. So very briefly, I will make just an introduction because Carolina already said, saying that this panel was mainly born to try to understand some additional factors into the impact of adoption of digital health solutions. And well, this is of course one of the holy grails, which is how do we make digital health work? And for sure, a lot has been said around this. And actually also in the Digital Health Society Summit in previous editions, this was discussed. But usually we go to different topics. And from the very practical example of the COVID-19 tracing apps, when we were discussing this previously in other situations, we were thinking that this was a very good example of when all of the technical aspects were taken, all of the member states developed the tracing app, the European Commission provided interoperability support, so everything should have worked. But the truth is that we understood there were differences in adoption, and a lot of them had to do with differences between countries. So this made us consider that perhaps there are more individual aspects, cultural related to countries and regions in the world that also impact on the use of specific digital solutions. So this can also bring to a very broad discussion. And what we want to do today is just to go around with our speakers and try to understand all of this different, I hope, new and specific aspects that we can discuss around cultural and regional factors influencing the adoption of digital health solutions. So with this, I would present the speakers today with me. We have Vanja Vasiljev, which is an associate professor from the University of Rijeka, Giovanna Ferrari, regional labeling lead at Pfizer, Barbara Di Camillo, professor of computer science in the University of Padova, and Carla Grubel, Ph.D. candidate from the Utrecht University. So they are also, as Carolina said, leading or managing European projects, and it's also in this, in representing these projects that we are here today. As they know, we are not hoping to present projects because this is not what we are supposed to be doing here, but of course to bring the experience that comes from these initiatives to the discussion today. So we will have an interactive conversation, and we will be also picking up some eventual questions that come from the audience. But for now, for the first round, I would start, if you agree, and in this case, asking Giovanna within the scope of the Gravitate Health Project, which you lead. We know that there are a lot of different countries and regions involved, and you had a very interesting approach on how to involve them. So perhaps you can tell us a little bit about this.
Thank you, Carina. The mission of Gravitate Health really is to bring forward innovative digital tools that can improve patients' access to and understanding of the healthcare information that they need to support them through their healthcare journey. So I think this question is actually really relevant to us, because ideally we want those tools to be as relevant to as many people as possible. Within the consortium, as we're running this project as a public-private partnership, I think, at the outset, we have something of an advantage there in terms of hopefully a road towards sustainable adoption, in that we do have involvement from a large number of different actors in the healthcare system, representing key constituencies to consider. And they're distributed, of course, through many countries. But also more directly within the work of the project, we have a number of testing scenarios identified in 8 or 9, possibly 9 different countries in Europe, where we will be undertaking proof of concept testing of our Gravitate Health tools and technologies. That testing will occur within the different local settings. We'll be relying to some degree on the resources available to us in those settings. So I think already we're starting to look into some of that variability that exists from country to country, and think overall, how can we from this bring forward a tool that is going to be as useful as widely as possible, taking into account those types of differences. And perhaps a point to note as well is that we're also looking into different aspects of the patient journey through those different settings. But I think that testing work within the scenarios that we have for the tools and technologies from Gravitate is going to be really critical to understanding how we can address different needs and different contexts that we find within the healthcare settings in different countries. So that's I think a fundamental aspect of how we're approaching it. But another really important angle that we're approaching this from through our dissemination and communication activities is by the engagement of healthcare ecosystems, not just within the EU, but also outside the EU as well. So we're in the process of onboarding 12 different ecosystems. I think 5 are within the EU and seven outside. And they're representative organisations within different countries that we can provide information to about the Gravitate Health tools, and we can also importantly gather information back, and we can use those recommendations within the project. So we're looking, I think, both in terms of communicating from an outreach perspective and building awareness of some of the capabilities of the types of tools and technologies that we can develop, but also importantly to gather information back. And those different ecosystems again provide us with another level of diversity in terms of different types of settings. So again, help us work towards something that is as useful to as many people as possible. And perhaps another point though to touch on, I think as well, is it's not so much regional or country based, but it's about the end user. And I think ultimately digital tools are going to be defined by their user friendliness, and that's going to be fundamental to the adoption. You can have the nicest piece of technology or tool in the world, but if it's not going to be easy and convenient for the end user to use and to make a positive difference, then you won't see that uptake. And within Gravitate, again, that user-centric approach is really foundational to the work that we're doing. We're looking, for example, through different mechanisms to channel sort of patient voice into the development work as we go along on an ongoing basis. And again, our scenarios, our ecosystems are part of that as well. But I didn't want just to emphasize the methods there. I think we need to also keep in mind the end users as well.
That's very true. Many thanks, Giovanna. At the end, it's all about it's all about people. So I think that possibly a very similar approach in terms of person-centric and end-user engagement also exists in value care. And I was very surprised when we were discussing this session and preparing it, that Vanja shared with us that they are a bit further in their project. They already did a lot of co-creation sessions. And you were telling me that it was actually possible to have similar challenges being brought by a lot of different countries. Can you tell us a little bit about this? Because we would always think that there would be a lot of differences.
Thank you, Carina. Thank you, Carolina, and organizers for this opportunity. Dear panelists and ladies and gentlemen, before I answer your question, I would like just to give a brief introduction into the project. Value Care is Horizon 2020 project on research and innovation action applied to call digital transformation in health and care. The aim of this project is to deliver efficient, outcome-based, integrated social and healthcare to older people that are facing chronic conditions in order to improve their quality of life and their families as well, and to achieve the sustainability of health and social care systems in Europe. In Value Care, we have 7 large-scale pilots. Those are Athens, Coimbra, Cork-Kerry, Rijeka, Rotterdam, Treviso, and Valencia. So every pilot has different chronic conditions and diseases. We have 4 target groups: older people 65 plus with chronic disease, formal and informal caregivers, social and healthcare professionals, and organizational and IT experts. So another important issue in this project is integrated care development, which is strongly related with digital technology. However, before the implementation and development of digital solutions that will be tested in those pilots previously mentioned, co-design activities were performed regarding the unmet health needs and also the IoT solution inputs in all pilot sites. So it was very interesting to see that in spite of these cultural differences, differences in healthcare systems, most of the pilots have similar requests regarding the virtual care pathway for the participants that were given to us by the participants. So we detected a lot of care pathways needed to be implemented in ICT solution, but the most common in all pilots is physical activity care pathway. Then there is nutrition in 5 out of 7 pilots, adherence to medications in 4 pilots, and additionally social support, socialization. So therefore, I am free to conclude that the unmet needs in different pilots refer mostly to the prevention activities that are lacking in all of those countries that will be involved in the piloting. So
thank you, Vanja. Yes, well understood. So for sure, from your experience, we need to invest more in physical activity and prevention, and this is well noted because I think we would all agree on this. I would perhaps pass now to Carla and ask her a little bit about the approach that you took to understand better this needs, but also the differences between what stakeholders tell you for Gatekeeper. I know that you had a very pragmatic and empirical analysis of this, and it would be very nice if you could share it with us.
Yeah, thank you, Carina. It's an honor and a great pleasure to be part of this panel today. And it's probably a nice shift from the needs to values, because our focus in Gatekeeper, so I'm working there with my colleague Alexander Peine, really is on values. And Gatekeeper is a large-scale innovation implementation pilot in the field of smart living environments, also for the aging populations. And it also has 9 European and 3 Asian pilot regions involved. And through open calls and twinning activities, the idea really is to scale up Gatekeeper innovations to further regions and countries across Europe and the world. But so if we want to scale up Gatekeeper health and social care innovations and create viable implementation pathways beyond the piloting phase, we think that we also really need to attend to values in context. So because values like autonomy, privacy, trust, or quality of life can mean very different things to different people, depending on the culture, on the kind of services and infrastructures available in a region, and also on a person's individual health and socioeconomic situation. And because values are often very deeply ingrained in organizational cultures and routines, they shape how new technologies are used or also not used. And therefore, my provocation for our panel today is that values are lived experiences and that we need to address this for sustainable scaling of health and aging innovations. And to come back to your question, Carina, so how we do this in our work in Gatekeeper is that we draw on the empirical ethics of care approach. This approach has been developed as an answer to the commonly used principle-based ethics. So what is the difference between the two? In principle-based ethics, people are seen as autonomous human subjects. To guide them in their actions, general and impartial principles are generated through abstraction, like autonomy or beneficence. The ethical judgment then is based on the fulfillment of these predefined principles. Now, what empirical ethics studies argue is that while such principle-based ethics has its value, high-level principles are too abstract and therefore unable to guide people in the more day-to-day moral conflicts that emerge when technologies are developed, deployed, and used. Therefore, for empirical ethics of care, the starting point are not general principles, but concrete everyday practices in which values emerge and value conflicts are solved. Humans are not so much seen as autonomous, but rather as relational subjects who are caring and cared for. In other words, if we want to take values seriously as key aspects influencing the scaling of health and care innovations, we should think about them not as abstract principles, but as dynamic and relational, and also attend to the value conflicts that emerge. So how do we do this concretely? I just give one example from our work in Gatekeeper. We go to the different pilot sites and study values in the actual moments of technology deployment and use. So that means we spend time with people, observe how they use Gatekeeper services in their everyday life and work, do diary activities with them, and conduct in-depth interviews and also organize co-creation sessions. And these interactions last over several months so that we are actually able to analyze how values and the regional and individual context shape the use and non-use of Gatekeeper technologies and services and vice versa. And insights from these and other activities are then shared with the Gatekeeper partners to inform the evaluation and scaling process, and hopefully also to make it more sustainable and closer to the everyday lives, values, and the diverse social, cultural realities of people living in the Gatekeeper pilot regions.
That's very interesting because, of course, that in usually, or at least in many cases, we think more of ethics as something high level and less embedded in reality. And now in Gatekeeper, you use ethics as a part of the co-creation approach, which I found very interesting. And this would lead me to Barbara, because one of the things that Carla mentioned was exactly that we need to understand people in context and how they are influenced by that context. And we are seeing this mostly on the end user side. But if we think of this on the developers of the digital solution side, there are also a lot of cultural aspects, predefined concepts that they have from their own experience and context, and that can influence the way they develop the solutions. And for example, in the case of artificial intelligence, may this somehow lead to biases in the way that algorithms are designed? I know that you have a lot of experience in this matter, and perhaps you can help us guide through this AI biases concept and impacts.
Thank you, Carina, and it's a pleasure to be part of this panel. Thank you for your question. Just to give the context, Brain Teaser is dealing with bringing artificial intelligence home for a better care of multiple sclerosis and amyotrophic lateral sclerosis. And related to your questions, in my mind, there are at least 3 aspects we need to take into account to avoid bias in developing artificial intelligence solutions. The first is maybe the more obvious, and it's related to the data collection. We need to be careful because everything starts from the data. And from the really beginning, we have to be to avoid excluding subgroups of patients or minorities that I mean, we need to keep them in the data and to collect the data which are representative of different types of population and different types of patients. The second aspect is related to the needs of the users, because we somehow sometimes think about the needs in terms of giving predictive outcomes, but the needs can change depending on the type of users. Users might be caregivers, users might be patients, but patients can be in different stages of the disease and their needs might change. And there can be subgroups, different needs. For example, in brain teaser, what we are focusing on among the other aspects are women that in the case of these diseases usually experience a lower level of care from their partners with respect to men. So in this context, they clearly have different needs. And we need to take this into account. And the third aspect is related to the need sometimes to stratify patients in different subgroups because the disease itself have different characteristics. And therefore we need to be aware of this and to study the data distribution in order, for example, to build different models in different subgroups of patients. So I think these three aspects, and the second one is not directly related to data, more to some cultural and social aspect is really, really important.
Yeah, well, we need to acknowledge that this is so broad as a theme that we could discuss this in so many different perspectives. And I thank you so much for bringing just a little bit of these different aspects today to tease also our participants. And this works because we already have some questions coming from the chat. And if you agree, I would pick up on some to be able to continue, because a lot of interest came directly also from the things you already discussed and the projects themselves. And I would perhaps help take some of these questions to shape the discussion. So we have one coming for Giovanna, saying that qualitative health is focusing on trusted health information sources. Can you elaborate on these and how national differences in these could impact adoption? Do you want me to go to repeat, or is it okay, Giovanna?
No, that's okay.
Yeah?
Thank you. Yes, that's right. I mean, we're defining our core trusted information source really as the electronic product information. So a digital format of the information that the patient normally receives, for example, with the leaflet in their medicine. That information is regulator approved, and digital formats offer some really important advantages there because you can communicate updates and changes in information, for example, more quickly. And there's a lot of work ongoing at the moment really to establish those types of digital formats across Europe and indeed globally. We're also interested in how that can interplay with health record data. We think that gives important opportunities to, for example, focus the information to make it more relevant to the end user and to really better meet the needs of the individual. And lastly, we're looking at health education materials, and that term really covers quite a broad spectrum, and those types of materials are often country specific and perhaps outputs of public health systems rather than regulators. And so it is a vaguer field, if you like, but that's the third, but it's an important area because that's where perhaps the patient might look to understand more about a condition, a healthcare condition, for example, or to find some additional information. So those are the sources that we're primarily working with and interested in within the project. I think in terms of how that connects to adoption, that at the moment, we do have some countries within Europe, for example, where we already have quite sophisticated and nice tools that offer access to healthcare information of this type, in particular the product information, the patient information leaflet content. We have other countries, though, where those types of tools are not so readily available, or if they are, then they perhaps don't offer such a sophisticated range of services. So I think on a practical level, one thing we need to grapple with within the project is to understand how we can add value both in those more sophisticated environments, if you like, as well as those more maturing environments in terms of healthcare information. We're likely, I think, within our testing scenarios to see a sort of something of a spectrum there and some different environments to work in. So I think we'll have a chance to sort of test that out from a practical level. But ultimately, we need to add value with what we're looking to do. And in some countries, you can start to see, well, if there's nothing there, then obviously there's a clear advantage to be had from such the type of tools that we're looking to put forward. In other cases, we need to look to the next level and how we can really build on what is current best practice.
Mm-hmm. Yes, and I understand this efforts of some kind of targeted support, but at the same time, harmonized support will be a difficult balance.
Indeed. And there is a piece there around, I know we're not focusing here on standards, but again, that is a very active area in the subject of electronic product information. And that's important, I think, not just from an EU perspective, but we want to think globally, then trying to globalize those conversations and bring together the appropriate sort of experts and stakeholders to move that forward in a way that can support perhaps a global uptake is in the longer term is also very relevant.
Yeah, indeed. Thank you, Giovanna. And this leads me directly to the question that was also in the chat for Vanja, because it's very much in the same flow as what you were discussing. People are asking, how do you plan to achieve integrated care within value care to fit all 7 pilots? So again, a difficult endeavor.
Thank you, Carina. Yes, the integration part is really challenging part, but with digital solution, it is doable. So within the value care concept, we developed the integration, which is supported by value care mobile app for the participants, for the older people, and the web app, or as we call it, value-based dashboard, which will be used by informal caregivers and health and social care professionals. The integration will be provided to participants by their multidisciplinary team, and support provided to participants throughout the value care mobile app. So this is innovative approach, and this approach fits all the pilots. So it was really challenging for our technical partners to do something that will fit all the pilots, but as I said before, it is doable. So how does it work in practice? So in practice, it means that every stakeholder from the multidisciplinary team can assess the data of the participants to check the adherence to care plan and to follow the progress of the participants, or even manage it, change it, or modify it according to participants' needs, because we are talking also about the personalized care. So value care is not the only project that has problems with the integration, as far as I know, because I'm included in another cost action, Net for Age Friendly, that also has challenges with the integration within the social health environment, and also try to apply digital solutions to integrate all those domains, let's say. And so integration is really challenging part, but digital solutions are really a good way to start with the integration.
And I would ask and tease you a little bit to this, if you allow me. Even if you find this nice way of doing it? How are stakeholders dealing with this? Like with this, I mean professionals, for example, from health and social care, and the organizations themselves, because sometimes this is a big challenging factor in integrated care, right?
Yes, we have some resistance within the health and social care professionals because of their work burden. And they, at the moment, they think that this will be additional burden for their work. But we have to find a way to motivate them to be a part of something new, to be to develop something that will happen anyway. Because by the 2035, all EU member states should apply value-based healthcare, which includes also the integration part. So we are struggling, but we see some progress.
Yeah, I can imagine, and I am sure that all of these initiatives help a little bit also to change mindsets and to progress. Well, I would perhaps drop a question or two to Carla and Barbara, if you agree, because we were now discussing about this different needs to harmonize further, to propose ways of making people let's say, more willing to think on the long term, to consider how to further use or approach digital health. And sometimes it is very difficult to explain what can be the mid or long term impact of digital health, because organizations and professionals are very focused on the urgent demands that they already have. But perhaps even despite all of these differences, even despite all of the challenges, there are things we can do to move on. And if I can go to Barbara, you were previously discussing about how to avoid bias, how to leverage on previous models and progress. If I could ask you, how can you do this? How can you leverage on previous models that you have, for example, in the scope of brain teaser that are for a specific population, and now move on and try to progress further and apply them to others and thus avoid bias? And with this, perhaps also being able to help the others to generalize a little bit or to harmonize the different approaches.
Well, if from one end, you shouldn't apply a model that was developed for a specific context in a different one. On the other hand, the models that have been already developed have a value, of course, and you should apply them first after a validation of their, accuracy and ability to predict on a new population with the same characteristic of the original one. And if you move to a different population, there are, let's say, a number of methodologies that are useful to recalibrate the model or to start the learning, leveraging on what you have already learned on the original population and adapting to the new one. And in this case, you maybe need a lower number of subjects with respect to the initial one, and you can, let's say, correct the model in order to fit to the new population. And in this context, I think that one of the big challenges in the following years will be really a topic which we talk about quite often, which is the data sharing. Because in order to be able to validate, to be inclusive, to extend the models that we already have to a bigger population, considering the different subpopulation and the underrepresented subpopulations, we need to share the data. Methodologies are ready, we need to share the data.
So if I go from Giovanna and Vanja's examples, for example, where a lot of data is possibly being collected in different countries, this would for sure help you, for example, in developing models and algorithms that would be more inclusive, because you would have more examples from different countries. Yeah, but we still have perhaps well, not all of the technical solutions, but also not all of the citizens' trust or organizational trust to share the data. And this is something fully understandable, I think, because it's a new world and everyone has a lot of concerns. So perhaps, Carla, you can tell us how could the ethical approach that you discussed before could be somehow used in this sense? How do you apply it in practice? Is it a possibility that if we understand better the context and the values of people, they can then also be either better informed, educated, and understand the value of data sharing, for example?
Yeah, definitely. So I think, I mean, we already talk about values for a long time, but what we still see is that in many projects, like when we use, for instance, the ECHAlliance Quality of Life Questionnaire, so one indicator that is measured is anxiety. And then respondents can tick a box, either I don't feel anxious, I feel slightly anxious, I feel moderately, I feel severely, or I feel extremely anxious. But so we gain some information from that, but we don't learn at all anything about what are they anxious about. So what and how does this anxiety relate to their personal context or to the regional context and to their culture and everything around? So it is still a very, even though we sometimes analyze values and include them in project evaluations, it's very abstract. And that will, we miss the cultural element in it. And I think that is something that is playing a very big role in how technologies are adapted or not. So I think here in the evaluation part, we really need to complement the more, the approaches we currently have, the more quantitative approaches with some more qualitative approaches that really look into people's everyday context and take them seriously.
Yes, that's a very good final statement, although we are not at the end, but that's a very nice key sentence, let's say, to take home. And perhaps because we have now 8 minutes to go, I could take one of the questions that came from the chat to all panelists and give you, well, if you don't mind, maybe we can keep the same order because you already know it, and ask each of you, if you had to select one, what is the aspect that you think needs to be promoted further if we want to go for a broader and more inclusive use of digital health towards societal good? What would be the key aspect that you think we need to work on, promote, and foster? Can I ask you, Giovanna, to take the floor? You were the first before. Thank you.
I do think important to move forward is converging the relevant stakeholders. I think one thing we're very mindful of within Gravitate is that there is a lot of change going on in different aspects of regulatory and healthcare processes that is very relevant. And in order for us to work towards a future in which, for example, in Gravitate Health, the EPI can find its place in that healthcare landscape, we really need all those wheels to sort of turn in harmony, if you like. I think it's very difficult and challenging simply because there are so many different interconnected factors and initiatives, but ultimately it may make the pace of change a little slower, but if to get the maximum benefit for the future, we do need that sort of convergence, I think, of expertise and direction.
So include all potential stakeholders, make them talk to each other. This would be a little bit what you said, if I understood correctly. Yeah, well, this one will be difficult to top. So Vanja, well, what would you select?
Yes, if I have to select the key component for broader use of digital solutions and digital health, I would go and vote for the patient's perspective. So this would include the ability to assess health information and services more immediately, such as through client-to-provider telemedicine or targeted client communication. Because as we saw from the co-design activities, we saw that our patients have long waiting lists for the treatments and not that good communication with the health providers and social providers as well. So those are some factors that could be improved. And also from the point of view of health workers, they need to be more accessible and to adhere to practices for delivering high quality care through interventions such as decision support and inclusion of questionnaires such as ECHAlliance that could be digitally implemented, and results can be seen in real time. So they can also see the things such as quality of life, lifestyles, physical functioning, and additional parts that are considering the patient's perspective and patient's life. So I vote for patients and health providers.
Well, those are really important aspects, and I think they are valued by all, but unfortunately they always seem to be difficult to implement further. But I'm very happy to see that at least from the side of this panel, I think all of us are working on this. Yeah, thank you, Vanja. Carla, do you want to continue?
Yes, yeah, I think it would be very interesting if we manage somehow to see technologies and people and their everyday contexts more in relation, less separate. Because for now, it often seems we create technologies and think about them as ready solutions and then implement them into the context of people, but that doesn't work, it seems. So see them more in relation and that they both influence each other. It's also, whenever we use technologies, we create new needs, like the phone 20 years ago, people did not need it, but now we do need it. So it's not only the needs that we have, but also technologies create new needs. So there is a mutual relationship, and I think that we should take more into account.
And how can we do that? Should we send digital engineers, developers, etc., into I don't know, hospitals, daycare centers, social care, or should we send more? Should we give more information to citizens on what can be developed, or both? I don't know.
It's also not only more information. I think also listen. That is really important. Listen to each other and work with each other. Yeah, that's definitely, and not always think as it's already a ready solution, but see how does it go together, and what is really remain open to the possibility that there are different kinds of solutions.
Yeah. Okay, so co-creation and listening together to different needs. Thank you. Barbara, your last but not least, and you will give us our takeaway to close.
I agree with Carla that co-design and listening take seriously what are the needs and the context is important. I would add education, because I think there is misunderstanding about what AI truly is. And so a solution based on AI need to be understood in order to start and go on in this dialogue and in this co-design path, let's say.
And do you think that we have already also on the digital side, let's say, the conditions to provide people with simple explanations where they understand how AI works? Because explainable AI is not that simple, I think. So do you think we already have the conditions to do this, or what do we need still?
Well, we have the condition. We need to think about how to convey the messages, let's say, because they are not that simple to convey, both because AI sometimes it's like a black box and but also, and this is related to explainable AI, so we need new solution to somehow explain which are the variable and which are the reason why we have a prediction rather than the other. But then the other aspect is related to the fact that I think AI sometimes is perceived like a magic thing that makes a prediction, but it is really based on data and it's based on algorithms. So there is let's say nothing really intelligent in that. It's just learning from the data using algorithms that have been thought by human beings. So this needs to be, I think, to be somehow put in a context of some educational material.
Okay, it's very well understood. And I think that as a short summary, if you allow me, and forgive me for any correction. So we need to put people at the center, engage everyone that is connected to a specific area or theme, try to make things simple and understandable, educate people, and put them in connection to each other in their different areas of work as well. So this goes either for patients, digital developers, organizations, policymakers, or anyone, I think. So at the end, we just need to connect people and connect the dots and try to progress more on understanding each other's languages, I hope. And I think this is what we did today. We are now at the final part of our panel. I would like to thank you a lot for this. It was while we had a lot of different aspects being discussed, I hope they were also very much understandable to the audience, because they are all connected, as we were discussing, and they all need to be taken into consideration in order to advance with digital health and care solutions. I thank you so much for your presence and effort to be able to have this open conversation, and I hope you enjoyed it as well as our viewers. Thank you so much, and enjoy the rest of the day.
Thank you.
Thank you.
Thank you.
Thank you.